Hello and welcome to the European Respiratory Society Guidelines in Focus video interview, a regular feature of the ERS Respiratory channel. The topic of this interview today focuses on the recently published ERS short guidelines for the use of as-needed ICS, inhaled corticosteroid with Formoterol, in mild asthma. My name is Omar Usmani and I will be leading the discussion today. I'm a professor of respiratory medicine at Imperial College London, and joining me today in this discussion is a friend and colleague, Professor Florence Schleich. Hello, Florence.
Hi, Omar. How are you?
I'm very well, thank you. Delighted to be joined by you today. Now, you're a professor at the University of Liege in Belgium, and you run a very busy specialist asthma clinic, and you're also actively involved in asthma research. And so you were absolutely the right candidate to be one of the co-chairs of this published guideline.
Thank you.
So during this session, we will first hear the perspectives of someone living with mild asthma who required the use of ICS, inhaled corticosteroid with Formoterol.
Hello, my name is Deborah Peñate Gomez and I have mild asthma. And having to take more active steps in managing my conditions. I cycle mostly everywhere. I did participate in a half marathon last year, and I did end up having to take oral steroids for that because I did run in cold weather, and that triggered my asthma. When I moved to the UK, what I had as soon as I signed up to my GP was an asthma review, and basically they asked me what medication I had, how regularly I was taking it. They did check how I took my my medication and made sure that I had an action plan. And also we had a peak flow measurement at the time. That being said, because I've moved around the city quite a bit, not all GPs are as diligent with that. So I currently have a preventer inhaler which does have a slow dosage of corticosteroids and a beta antagonist. I do still have a reliever inhaler with me just in case. Not that I use it. I normally use it once, maybe twice a year because by keeping on top of my preventer inhaler, that means that I'm not as reliant on the reliever inhaler. It was an exciting opportunity. I've always been interested in research, but obviously don't have the background to be involved actively in it. So that's why I was like, oh, this is my opportunity. So it was really interesting and exciting to be part of those very complicated conversations. I will admit, most of the times, the conversations just went over my head. I was able to input on certain elements, which for me are very important from a patient point of view. For example, education is key, understanding what medication you have, why you need it, why do you need to take it regularly. There's an element of fear with regards to corticosteroids and people not wanting to take them because they have bad press. There was also an element around the cost of medication and how with the recommendation on the guideline was around moving to a single inhaler rather than having a preventer and a reliever, and that would mean half the cost for the patient. And also if we're to consider things like the environmental impact of our inhalers, especially the ones that are sprays, not the dry powder inhalers. The other ones are very pollutant. I would say when talking to a patient, try to step into their shoes and remember that they might not understand the science behind it. So talk in plain language. I do feel proud of being part of this exercise and these guidelines, because hopefully they will have a positive impact on patients and will lead to less visits to hospitals and less visits to emergency treatment because of asthma attacks and exacerbations, and it will have a big impact on your quality of life.
So, Florence, please tell us what made you decide on the subject of the guideline?
Our task force was set up by the European Respiratory Society to provide evidence-based recommendation on the use of as-needed ICS Formoterol as treatment for mild asthma. And you know, asthma is an inflammatory disorder of the airways, and anti-inflammatory treatment is the cornerstone of asthma management. And we know that until 2018, the GINA recommended a pharmacological strategy based on a regular maintenance treatment with an anti-inflammatory treatment with short-acting beta-2 agonist as rescue medication. And patients with milder asthma were recommended only as needed SABA, but short-acting beta-2 agonists are ineffective on this underlying inflammatory process. So the chronic treatment with ICS alone, we know also that it has been associated with a poor adherence to treatment because relief of symptoms is not as quick as with short-acting beta-2 agonists. So patients self-manage their condition using the medications when they feel they need it, and they adjust the treatment by increasing the intake of short-acting beta-2 agonists, aiming for immediate relief of the symptoms. So this may result in short-acting beta-2 agonist overuse, which has been associated with an increased risk of severe exacerbation. So the concomitant use of an inhaled corticosteroids in addition to a rapid bronchodilator as reliever medication, the so-called AIR approach, would provide rapid relief while administering anti-inflammatory therapy with the reliever. And there are recent data from randomized control trials showing the equivalence, the use of as-needed ICS Formoterol compared to ICS plus short-acting beta-2 agonist in mild asthma. And now GINA recommends its use as first-line treatment in mild asthma. However, EMA did not approve its use as rescue medication yet. So to provide evidence-based recommendation, the task force defined two big questions that were assessed using the GRADE approach. And the task force used the outcomes with the treatment to develop recommendation for a pragmatic guideline for everyday clinical practice.
So what were then these two PICO questions, the population, the problem, the intervention, the comparison, the outcome? What were the two PICO questions?
The PICO questions were, the first one was, is as-needed ICS Formoterol without maintenance treatment the preferred treatment compared to a regular low-dose ICS maintenance treatment plus as-needed short-acting beta-2 agonist? And the second PICO question was exactly the same beginning. So is as-needed ICS Formoterol without maintenance treatment the preferred treatment compared to as-needed short-acting beta-2 agonist without any maintenance treatment? And the targeted population was adult and adolescent patients with mild asthma, so receiving GINA treatment step 1 or 2. And we had a methodologist who designed and conducted the literature searches in October 2021 in various databases. And Iona, Agash, and me, we screened the studies based on predefined inclusion and exclusion criteria. And the panel decided that they would review the evidence separately for adults and adolescents.
So then, if I ask you then in PICO 1, what were the conclusions for the use of ICS Formoterol, inhaled corticosteroid Formoterol, as needed compared to SABA, short-acting beta agonist?
So Omar, I must say that this was the easiest PICO question to answer to. So we had a lot of publications, 547, of which we selected only 3, the Sigma 1, Sigma 2, and Novel Start. And all studies used budesonide as the ICS component. All statistically significant differences were in favor of as-needed ICS Formoterol. There was a reduction in the number of patients experiencing severe exacerbation, a reduction in the analyzed exacerbation rate. There was also a reduction in patients going to the emergency department. There was better improvement in asthma control and quality of life with ICS Formoterol as needed. And also the total systemic corticosteroids exposure over 1 year was lower for the as needed ICS Formoterol arm. The change in pre and post BD-FEV1 from baseline also favored the use of ICS Formoterol as needed. And there was no difference in adverse events between both strategies. We also looked at data on mortality, but the data were really too small to be analyzed. And we as I told you, we selected adult patients and we analyzed the data from adolescents apart. And regarding the adolescent subgroup, there were less studies and there were differences favoring once more as needed ICS Formoterol. There was a better reduction in severe exacerbation, a better improvement in asthma control, and also a reduction in the mean daily ICS inhalations. So to conclude, the task force recommends that adults and adolescents with mild asthma should use as needed ICS Formoterol instead of as needed short-acting beta-2 agonist. And we decided, and we all agreed on that it was a strong recommendation, but low certainty of evidence because we had few studies. And this recommendation is based on the benefits of this as needed ICS Formoterol strategy in mild asthma on the different outcomes that I just listed. And the risks related to as needed short-acting beta-2 agonists in the absence of anti-inflammatory treatment, especially in this patient with mild type 2 asthma. But we, of course, have to keep in mind that the implementation of this recommendation is hampered in countries, in all countries, including European Union countries, where as needed ICS Formoterol is not yet approved for the management of mild asthma.
Yeah, no, thanks very clearly for explaining the risks and the benefits and the outcomes from your PICO-1. It's very clear, as you described, and also just reminding us about the approval in certain countries, as you say, even including the European Union countries. So if I then lead you on to possibly the more challenging PICO, your second PICO, what were your conclusions, or what were the conclusions of the task force regarding the use of as-needed ICS Formoterol, inhaled corticosteroid Formoterol, without maintenance treatment, compared, here the comparator, to regular dose ICS maintenance treatment plus as-needed SABA, short-acting beta agonist?
It was more difficult for that one. We'll understand from the results. We also had a lot of publications, 547. 6 were finally included in the analysis, and all 6 studies used budesonide as the ICS component. And there were no difference in favor of ICS Formoterol use. There was no significant effect in terms of reduction in severe exacerbation, in terms of emergency room visit or hospitalizations. There was no clinically important difference in quality of life or asthma control. There was a reduction in the mean daily ICS dose, but we have to know that the change in pre and post BD FEV1 from baseline favored the maintenance ICS. And FeNO values at week 52 were higher with as needed ICS Formoterol. So there was no difference between as needed ICS Formoterol and maintenance ICS plus SABA in the number of patients experiencing adverse events. And we suggested that adults with mild asthma use as needed ICS Formoterol instead of regular ICS maintenance treatment plus as needed short-acting beta-2 agonist, because it was equivalent results. And we were more cautious for adolescents with mild asthma use. They should use either as needed ICS Formoterol or ICS maintenance treatment plus as needed SABA. And this was a conditional recommendation with low certainty of evidence. And once more, we have to keep in mind that we should follow up the lung function as the change in pre-bronchodilation and post-bronchodilation FEV1 from baseline favor the maintenance ICS compared to as needed ICS Formoterol. So in this patient, we should monitor the lung function.
Yeah, and you'd expect me to say this, Florence, but the advantage also is you've got the ICS Formoterol in one device rather than two separate devices as well. That may require different inhalation flows. So did you evaluate the value of such a strategy for patients?
Yeah, one of the strengths of our task force was the inclusion of patients representative in the panel. So you already heard Deborah's testimony, and we know that during the discussion, the patient's representative highlighted that healthcare professionals should provide information to help the patient to understand that a combined regime may reduce the oral corticosteroid exposure as compared to short-acting beta-2 agonist only, as well as explaining the differences in side effects profile of the ICS and OCS, because we see that in the practice. Sometimes patients are really reluctant to take the ICS because of the name corticosteroids, and they think about all the side effects linked to OCS intake. So we have to clarify that with our patients. And since the patients consider the speed of onset is really important, it is necessary to explain that the speed of onset might be a little bit different for short-acting beta-2 agonist, and ICS Formoterol is needed, and that there may be variability between patients, with some patients reporting slower onset of efficacy with the Formoterol as compared to salbutamol, for example. However, it is also important for patients, it was something they insisted on, to have the choice. And some patients may prefer the regular use of maintenance ICS. And we also know that the type of inhaler device is really important for some patients. If you take the example of the dry powder inhaler, it is more difficult for patients with impaired inspiratory flow, but it can be less deleterious for the environment. And environment was really coming during the discussion as an important point for the patient who were involved in the panel. And the last point was the cost of ICS Formoterol. It can be higher than that of short-acting beta-2 agonist for patients in some countries, such as Belgium, for example. But we also know that in other countries, such as England, as needed ICS Formoterol combination would be cheaper for patients in healthcare system, because in England, they pay a prescription charge per item prescribed. So it's cheaper if you have a combination. So I think future cost-effectiveness studies in different countries would be of value to evaluate this point, because the cost was important to the patient too.
Yeah, no, your point about communicating with the patient and explaining the management strategy is really important, and you went through that really nicely with the points that you made. Thanks, Florence. So if I bring you back, let's come to the point of lung function. So when should we as clinicians be cautious about lung function decline, Florence?
In mild asthma, it can be, we can think it's less important, but it is. And in mild asthma, lung function should be monitored over time. In this patient in whom we decide to start a treatment with as needed ICS Formoterol, we must detect the fast decliners, because in that case, we have to give the patient chronic treatment with ICS Formoterol or at least ICS. The second group of patients in whom we have to be cautious is the patient who are poorly adherent with maintenance ICS, because these ones are also at risk of a decline. And the third group of patients in whom it is important to follow up lung function is the adolescents with the low lung function. In particular, if you see that the lung function is worsening over time, then a regular use of ICS treatment should be considered in these patients.
Yeah, no, you make those points very well, and highlighting those fast decliners really with respect to monitoring lung function. So is the reduction then in the mean daily inhaled corticosteroid dose with the ICS Formoterol combination compared to inhaled corticosteroid plus as needed SABA, is it of clinical importance?
Yeah, I think that the reduction in mean daily ICS dose with this as-needed ICS Formoterol strategy as compared to the maintenance ICS plus as-needed short-acting beta-2 agonist could be important if you look at the long-term data. It should be studied more in depth. And there is this very recent paper published in Nature Medicine by Kakru and co-workers showing evidence of systemic effect of chronic use of low-dose ICS. So the lower dose, the better, I think. But we also have to look in the future at the impact of these therapeutic options on the airway remodeling. It is also something that could be further assessed in patients especially with raised type 2 biomarkers, and also those who are poor perceivers of asthma symptoms. And future studies should also further investigate the cost effectiveness for different healthcare systems. I think it's something we have to do in the future.
Could you give us then an example of a specific case where the guideline could be used?
I saw a patient in the asthma clinic last week with a recent diagnosis of type 2 asthma. He had elevated FeNO, 63 ppb, blood eos count at 430 per microliter. And he received a treatment with short-acting beta-2 agonist by his GP. And he came to the asthma clinic 3 months later. During the investigations, he had a normal baseline lung function. He had a good asthma control, and he used salbutamol twice during the last 3 months. So he was not at all limited during exercise. So we know that these patients are really not using a lot their treatment, their reliever, but we also know that these patients with type 2 high mild asthma are more at risk of future exacerbations. And maybe we should not consider this patient as having mild asthma. So I think this is a perfect case to switch to as-needed ICS Formoterol for this patient, because he has very few symptoms and he has a normal lung function, so he probably does not need a daily treatment, but he is at risk of future asthma attacks. So a reliever containing ICS is of utmost importance in this case. So I think this type of patient should never be treated with a SABA alone. However, the as-needed ICS Formoterol can not be currently implemented in Belgium, in the European Union. So given that as-needed ICS Formoterol has no regulatory approval for mild asthma, so this means that this patient with mild asthma within the EU might be missing the benefit of this treatment approach. So I think it's really important to move on and to try to have this approval in the future.
That's a really nice case. Normal lung functions, reasonable symptoms, but you remind us of the risk. And maybe sometimes we forget that when we see somebody who's really well. The risk, the future risk, is really important. And that's certainly, you've highlighted that. And again, the problem of the regulation of this product. Florence, really, it's been great catching up with you, getting an idea of the background of the guideline, what your PICO's found, and you've translated it into a very pragmatic way in terms of what we can do with our patients in the clinic. So thanks very much for joining me today and for sharing your expertise with us all. Florence, on behalf of the task force.
Thank you all for listening. Thank you, Omar, for the discussion. Very interesting discussion.